All right. Hey, good afternoon, everyone. Excited to be with everybody here today with our quarter one webinar titled Why Occupational Health Matters More Than Ever. I was hoping before we get started, obviously we don't have cameras running here today for this webinar, but if anybody's out there dialed in, participants, if you wouldn't mind dropping like a thumbs up or hey, I can hear you in the chat. Okay, just want to make sure audio, video, you guys can see the slides okay. You guys can hear my voice okay. If anybody would mind dropping a quick up in the chat before we get too far into this and realize our audio isn't working, I would really appreciate that. Hey, Lindsay, thanks so much. Thank you, James. Yeah, awesome. Thank you, guys. Cool. Well, hey, we'll jump right in. Yeah, again, let's talk about why we're here today. So really the goal of our conversation today is to give you guys tools and resources to reduce, healthcare costs within your organization and really just rethink and reframe healthcare as a competitive advantage for your company, for your organization, and giving you guys some tactical tools that you guys could do tomorrow based on our kind of experience within this industry to kind of go out and attack that. So I think from an agenda perspective on the next slide, we're going to be pretty, me and Dr. Turnbow are going to be pretty quick kind of to the point today. We're really more focused on giving you guys some tools, resources towards the end of this discussion. And then I think, Cassie, we have some time blocked for some Q&A at the end of this. So anybody out there as you're listening, if you want to drop a question in the chat, Cassie's going to be monitoring that throughout the webinar and kind of helping me and Dr. Turnbow stay on track at the end of this. So the goal is to have plenty of time to field your questions, because that's really what we're more interested in. The last thing we want to do is just have a strategic, theoretical discussion. We want to hit you guys with the quick 30-second overview of the theory and our experience, and we want to jump into the tactical, granular stuff that you guys can take back and start winning these challenges tomorrow. So real quick, 5-point agenda here. I won't read this verbatim for you, but we're going to spend quite a bit of time on section 3, which is what we're calling our solution, or the 5 pillars to win in occupational medicine. All right. All right, real quick, I'm gonna tee it up or hand it off to Dr. Turnbow, if that's okay, to introduce himself.
Yeah, hi, I'm Kyle Turnbow. I am the medical director for HealthWorks Medical. I'm fortunate enough to have had the opportunity to be trained in occupational medicine at the University of Pennsylvania. Have a master's of public health from Purdue and board certified in family medicine and occupational medicine. Started HealthWorks, gosh, in the Stone Ages, it seems like now. I think we started in 2007. Does that sound about right?
Yeah.
And we've really had the opportunity to work with a number of clients on unique, I would say, solutions to their problems. I mean, I think particularly in the river industry, it's a whole different ballgame, a whole different animal. Certainly our work in the Department of Energy and some of the chemical plants, also just a unique challenge in providing care to their employees, and choosing the right person, putting them in the right position, and protecting them from injury and illness is what we're all about. And I think we've been fortunate enough to develop some unique strategies to help that. And I think that's what we're going to pretty much talk about.
Absolutely, I agree, and thank you for that, Dr. Turnbow. My name is Patrick Howell. I'm the Chief Executive Officer here at HealthWorks Medical. Majority of my healthcare background is in military medicine. Kind of had the unique privilege to serve as a U.S. Army medical officer for the past 20 years. Literally been all over the world in every type of medical operation you can think of. And I joke with Dr. Turnbow, military medicine is ironically very similar to occupational medicine when we're talking about how do we keep people safe, how do we find the right people for the right job at the right time, and make sure that we have a force health protection strategy in place to make people successful at their mission, which in context of today's discussion is working within your organization, right? So really excited to be here with you guys today. I'll try to just briefly kind of tee this up. The title of the presentation today is Why Occupational Health Matters More Than Ever. So let's talk about kind of what's unique today versus maybe wasn't, 5 or 10 years ago. So today, the U.S. healthcare system is essentially one of the largest economic forces in the world. If you just measured it from an economic output perspective, we have largely the 5th largest economy in the world when we just look at U.S. healthcare dollars being spent annually, which is just crazy to think about. I think our U.S. healthcare spends tracks just behind the entire GDP of Germany.
Yeah, which is crazy.
Which is crazy to think about. So obviously, it's a monumental shift in cost and resourcing that we're facing today. And this, guys, this is a really broad problem, right? We're not going to solve U.S. healthcare spending in a 45-minute webinar here today, but I do think setting the stage on how this is affecting your organization and making sure we have some solid understanding of what we're up against is really important.
The only thing I would add to that is the adage that you get what you pay for is sometimes correct, and in a good percentage of times it is correct. But in U.S. healthcare, I think the amount of money we spend on healthcare does not necessarily equate to getting better quality care. And so one of the things that we've been focused on at HealthWorks is being able to provide the highest quality care, early interventions, the right care in the right spot at the right time to avoid some of this unnecessary cost expenditures. Because if you look at that $4.5 trillion that's spent in the United States economy, the majority of it has nothing to do with direct patient care. The majority has to do with a lot of individuals, third-party administrators, people in the middle who are making a good percentage of that dollar. So I'm pretty proud of the uniqueness that we have been able to provide for employers to circumvent some of that additional cost.
Great point. And it's actually a really good segue for our next slide. Like, despite what we're spending, what's kind of the clinical state of U.S. healthcare? We're spending this huge chunk of money. What are we getting from a clinical perspective?
We're on life support. So we're spending a lot of money for really poor outcomes.
I think we had like 2 or 3 buckets here we were going to kind of hit.
Yeah. So, I mean, you would think if we're spending more money on healthcare than anywhere else in the world, that we should live longer and have better quality health in the years in which we are living. And unfortunately, that's just not happening. Our life expectancy is significantly below most of the developed world country leaders. Our preventative mortality, things that chronic diseases that we could easily intervene and prevent, and certainly this a lot goes to lifestyle, but it also goes to lack of recognition and intervention is the highest. And our maternal mortality, and unfortunately, maternal mortality has a lot to do with not necessarily access, but in our country, a lot to do with substance abuse. We have, unfortunately, a lot of mothers who are addicted to substances that are resulting in abnormal and unacceptable outcomes to the infant.
Mm-hmm. Good point. And it really kind of transitions nicely to the next slide here, which is how does this directly affect the employer? There's a couple of things here that I think are just really important for you to understand within your organizations. Currently, roughly half of Americans are covered through employer-sponsored, healthcare plans, 155 million plus. The average annual family premium is now over $23,000 a year. Those are the employees paying that portion, not just the employer portion that you guys are paying. We're seeing growing deductibles and cost sharing, which is really turning to the employer side, where now we're seeing a rise in employers take on a rise in self-funded plans where employers are directly essentially financing the risk associated with their healthcare insurance product. So now, instead of traditionally just being a consumer of healthcare, your company is essentially just another financier kind of in that whole economic cycle, right?
Yeah, the irony of this is when we started HealthWorks in 2007, it was when we initiated a direct to primary care concept for one of our larger clients to provide health care for their employees and dependents as a self-funded employer. The average cost for family premium there was closer to $12,000. Mm-hmm. So we've doubled that. And what we were seeing back in 2007-8 was costs going up 25-30% every year. And there was a little bit of a stabilization of that, but most recently, over the last few years, we're seeing those kind of increases again. And there just doesn't seem to be any end in sight for that.
Yeah, I think the running joke that we've seen is, if your healthcare partner or your broker comes in and lays down a renewal that's less than a 10% cost increase, you're lucky. You're lucky and maybe excited.
Yeah,
exactly. So, which, leading into, the point is really clear. Employers desperately need a cost-effective health strategy to turn the tide on this, right? Let's jump to the next slide, Cassie, if we could. So a few things that we're seeing on the front lines here, delayed injury reporting within employer organizations, and, the impact of that is obviously challenges within your admin and compliance environment. Overuse of ER, this is a big one too. When your default, kind of healthcare button in the occupational health space is like, well, hey, I cut my finger, I stubbed my toe, send them to the ER. There's a whole plethora of kind of downstream, secondary and tertiary effects associated with that. And Dr. Bono, you might have some comments on that.
Yeah. Well, delayed injury reporting. So because healthcare insurance it has become so expensive, the natural and really the only thing the employer can do is to shift some of that cost share to their employees, which results in higher premiums, higher deductibles, higher co-pays. And so, unfortunately, a lot of families and employees can't foot that bill. And so there tends to be, what we see is a lot more tendency for people to claim things to be work-related that are probably actually not work-related. So this delayed reporting, I think, goes a lot to, hey, I hurt my back at home doing yard work, but now I'm going to wait to get health care for it so I can get to work, claim that I hurt my back at work so that there's no copay and no deductible. And I think if any HR professionals or safety folks that are on the line will attest that that's something that we're constantly dealing with, really doing an injury analysis to make sure the mechanism of injury that's described, correlates with the actual injury we're seeing. I've seen that just skyrocket over the last few years, particularly because of, I think, high deductible personal health insurance. And then the other thing is people wait so long because they don't want to access the traditional areas to provide care, like their primary care physician, that they end up waiting too late and they end up in the emergency department. And if anybody on the phone call has been to the emergency department lately, you're not entering the front door without a $10,000 exit at minimum. And that's just the way things are now with the emergency department. And so you want to keep your people out of the emergency department unless it's a true emergency as much as possible, because those are some of the higher cost points. If you go to the emergency department unnecessarily, not only is the bill higher, but the follow-up is fragmented. And so what is necessary, I didn't even read that, but the number 3 here is fragmented follow-up care. It's so fragmented that you end up in places you don't need to be. So if you have a sprained ankle, the ER's result, their discharge is going to say, follow up with the orthopedic clinic. Well, an orthopedic clinic costs 4 times as much as a primary care office. So you're already putting them in a higher cost point, and by the way, no improvement in their outcomes. So, just having someone involved or having a procedure involved that puts the patient in the right place at the right time to get the right care is extraordinarily important.
Absolutely. And I think the take-home message on this slide is the traditional healthcare ecosystem is really not equipped to deal with the nuance and the specificity of occupational healthcare.
Right. I mean, most of healthcare now is in a street and street capacity, particularly emergency departments and urgent cares. There's so much strain on those folks to see people quickly and to see a lot of volume to be able to meet the bottom line. And unfortunately, the drivers of that tend to be hospital systems, and they grade their folks based on those metrics, how many people you can see, how quickly you can see them, and how much money do you make. And what that ends up to is that street and street kind of mentality, which leads to fragmented care. But then also, they have no idea what the employee does. They have no idea what the job description is. They have no idea how the safety sensitivity of their job may impact themselves and others on the job site. So having medical providers involved with every aspect of this, putting them in the right spot at the right time, making sure they have appropriate follow-up, making sure that it's a provider who understands the dangers associated with their job and what their essential job tasks are, makes all the difference in the world in providing healthier employees who are ready to do their job in a safe manner at a lower cost point.
No, I mean, all good points. I think a lot of these are relatively obvious when we see them, the outcomes associated with them, the ER bill, the work comp claim. But let's talk a little bit about some of the hidden employer costs that maybe aren't so obvious when we talk about an inefficient, healthcare strategy. So obviously we have a few listed here on the slide: absenteeism, presenteeism, obviously the difference between that. When we have, folks miss work, that's one thing. But what if you have a whole bunch of people at work who are maybe there, but they're just not optimal to perform the job, right?
Yeah, absolutely. I think presenteeism may be as dangerous as anything else on that slide, because, the stress and strain that your employees are under now is at an all-time high. I mean, the cost of everything is high. The stressors on parents are high. And so depending on what's going on in their world, really impacts their ability to be fully present to do their job efficiently and safely. And so if we can provide them better quality care, to be present from both a physical standpoint, but also a mental health standpoint, I think is an extremely important factor that has to be addressed in any employer's healthcare system. Providing an employee who shows up ready to work, on track, not distracted from a health-related issue or a mental health issue, is extremely important.
And we're going to discuss here shortly, what are some real mechanisms or metrics that you guys can kind of operationalize to kind of capture and start measuring and tracking some of these things. So next slide. Dr. T, I might let you kind of take the lead on this one. Really we're trying to get into, I think we kind of got into this a little bit, but why is the traditional healthcare model just ill-equipped really to support our workforce?
Yeah, so I appreciate the question. I think it really comes down to in preventive medicine and public health, you really, everybody in the realm knows that primary prevention is always the best. So when I say primary prevention, it's like an ounce of prevention is worth a pound of cure. And that really is so true. But the way our whole healthcare system is designed, and particularly with the way the current healthcare system punishes people for accessing care with high deductibles and high copays, people wait, and they wait until they already have a disease or the disease is out of control, which is secondary and tertiary prevention, that it's too late. So I think a healthcare model that treats the worker, in the context of the job that they're supposed to do, but also treats them and identifies potential for injuries or illness before they actually come to fruition, is the preferred model. Primary preventive model that is focused on ensuring that a employee has the health and the mental fitness to safely perform their job tasks before they get injured is where you want to be. And unfortunately, for a lot of the healthcare system, that's just not what it's designed to do. That's kind of what our structure is designed to do. So job function analysis, I always say, how can you truly take care of somebody's needs if you don't have any idea of what their demands are. If you don't have any idea what their specific job description is, if you don't have any idea what their potential hazard exposures are, how can you plan for that? If you have no idea what their demands from their employer are, then it sets everybody up for failure. And so a lot of times, healthcare for injured employers, if you're waiting, or injured employees, if you're waiting to access healthcare once the employee has gotten ill or injured, you're 2 or 3 steps behind, right? I think the better model is, let's identify the correct employee for the correct position. So do a good post-offer test. Be sure that you are making sure that you know exactly what you're getting when you're hiring an employee, that there's not hidden risks associated with their past medical history or their mental health. I think or their physical fitness. I think it's important to understand the job task and to marry that with people's fitness to be able to safely perform those tasks. And so I think a post-offer test that is thorough and specific to your particular job is critical in getting the right people. And if you hire the right people who are physically fit to do the job, your injury rates will go down. And then if you have in place a plan to make sure that they stay fit and that you're doing all the things you can to prevent them from getting injured, stretching plans, physical fitness plans, periodic evaluations to make sure you're catching things before they become catastrophic, I think are always very, very helpful. And then third, everybody's going to have injuries. People are going to get hurt. It's just part of the world. But after you've done everything to make sure you hire the right person and that you've done everything you can preventatively to prevent them from getting hurt with your safety colleagues, you have a clear plan on what you're going to do when they get hurt. Where are we going to try to, how are we going to try to access care? Where are our preferred locations to access care? And then once we access that care, what is our system to follow these people through to make sure they get appropriate follow-up and coordination of care in the right spot? And then what is our plan to get them back to work at the most reasonable time and in the safest way possible in a return to work program? And I think what, unfortunately, in the U.S. healthcare system, a lot of that's fragmented. You go one place to have maybe you have a post-offer test at a doc in the box, and then that information is put on a shelf and never accessed again. And then you have a wellness program that's put on by your health insurance just so you can check the box. Nobody ever does anything with that information, so it just sets on the box or sets on the shelf. Then somebody gets injured, they end up in an urgent care or an ER that has no idea of any of the other things that were occurring, the pre-employment or the annual wellness, so they don't access any of that. And that fragmentation of healthcare leads to what you should expect, which is fragmented delivery. If you have 3 or 4 people doing those roles and they don't communicate and none of that stuff is shared, you shouldn't be surprised to have poor outcomes. And I think that's what we do so well, is because we take ownership of every aspect of that, to take that information. Once you have a wealth of information from a post-offer screening that's thorough and job specific, and you share that with the ongoing evaluation and management from a wellness standpoint to prevent people from getting injured. And then when they do get injured, you have that information, you know the patient, and you're able to help specifically guide care and get them back into the return to work process. It just works so much better. Now, not everybody has that luxury to have those, in alignment, but I think that's the ideal situation.
And you made a comment, the old adage, an ounce of prevention is worth more than a pound of the cure.
Yeah.
I think, unfortunately, somebody told me this years ago. Apologies, I can't remember the name, but yes, that is true. But unfortunately, I think the model that we live in today is an ounce of cure pays more than a pound of prevention in the traditional healthcare model.
Absolutely.
And,
Yeah.
it's about getting folks to the procedure, to the ER, the high cost centers, to get those encounters, as you mentioned, where I think what we do on the occupational health perspective is really flip that model and really try to look through that old adage.
So, I have spent my entirety of career as a staff physician at 2 different hospitals, and I love my hospital colleagues. I think they have a critical role in healthcare. but hospital systems in general make money on specialty care. They make money on emergency departments and surgeries and high cost of care. And so they're going to utilize locations, primary care and their urgent cares to feed that mechanism.
Sure.
And that's just the way it is with healthcare. So our challenge as the representative of the company and being advocates for their employees and their health care is to access the right care at the right spot. I keep saying that, but that's really what it boils down to. Keep people out of the emergency department when they have no business being in the emergency department. Keep them out of the orthopedic clinic when they have no business being in the orthopedic clinic, but be able to utilize those things when you need them and help guide people through it.
Absolutely. And I think that's a good kind of segue here to one of the last points we're going to make before we get into the actual strategy piece is, let's jump to the next slide, Cassie. So here, like, how do we shift our mindset from thinking about Occ Health from like a compliance function to really like a strategic lever within our organization? Here's some areas like business functions that we would kind of want to challenge or dig into as we just kind of audit your overall strategy. We want to look at, maybe you have an injury treatment policy, but what's your prevention and readiness policy? What does that look like? Talk to me about that. How can we build that out to kind of mitigate the latter? Compliance driven to risk driven. Obviously, we want to look at, your healthcare model as a risk mitigation tool within your broader, operational ecosystem. We want to shift that relationship from a vendor relationship, kind of Dr. Trumbo hinted at this earlier, to more of a strategic partnership. A lot of the groups we work with, we're in the boardroom. We're sitting by the C-suite staff. We're having these strategic level discussions as far as how Force Health and medical readiness drives and supports their overall strategic plan for them as an organization, whether it's through the people, whether it's through the technology or the processes. Your force protection model as an organization is an umbrella that wraps every single thing you do. Obviously, we want to talk about data. I'm a data geek. We'll talk more about that here at the end. And then Dr. Trumbo hit this perfectly, like cost center mindset to an ROI mindset. Like, hey, how can we get the conversation from, golly, we got a 14% renewal this year to, hey guys, we're actually investing intentionally within our force health protection strategy. And we know if we do A, B, and C, it's going to equal D, E, and F within our business, right?
Yeah, I think a lot of that in your military background, all of this seems like a good military plan. If you, Washington was smallpox ran through his troops and killed a number of them very quickly. So he recognized very quickly, if you want to win the battle, you got to take care of your people. And unfortunately, with the way relying on the U.S. healthcare system and its current setup to provide care reactive to your injuries is going to set you up for failure in the future. You should expect to have a high absenteeism and presenteeism be very, very low, and turnover be very high, and your costs to be extremely high. I think if we can, not that having a strategy is going to fix everything, because you're going to have people who are sick, you're going to have people who come to work that are less than 100%. But if you don't do anything to think ahead and plan ahead, then you should expect that you're going to have worsening outcomes.
Absolutely. Absolutely. So this is the point of the presentation. For those of you all that are still with us, this is where we need to perk up, kind of lock in, because this is where we're going to give you the juice here, if you will, as far as, okay, I know it, guys. I've listened to you. It's complicated. It's challenging. Here's all the hurdles we're facing. Like, so what? Like, what can I do? What's some real world things? I'm sitting within my company. I'm in charge of our health program, or I'm in charge of my safety program, or maybe I'm in charge of recruiting. I'm talent management. Like, what do I need to be thinking about as far as proven, tactical level things that I can implement or recommend within my company to drive change? So we call this like the first 72 hours, like we're really getting into just the injury response piece here, but excited to kind of, Dr. Trumbo, talk a little bit about your perspective on a few of these things that we want to share with the audience.
Yeah. So with musculoskeletal injuries, if you are HR or safety on the call, you know that musculoskeletal injuries tend to be your highest call volume and your biggest issue. So the American College of Occupational Environment Medicine has a treatment protocol that is pretty good. And actually, if you are early in your interventions for musculoskeletal injuries, that does not include the following things. It does not include rushing off for an x-ray. It does not include an MRI. It does not include early medications. None of that stuff actually changes the outcome. It changes the cost and it changes the recordability, but it does not actually make any difference in how quickly an employee gets back to work and recovers from their injury. What does make a difference? Making a difference in early musculoskeletal stretching, local care, ice, rest, ice, compression, elevation, all those things people know, and intervention with a therapist or a exercise physiologist. Those things actually make a dramatic difference in how quickly people recover. Keeping them on site, keeping them working makes a big difference on how quickly they come back. And I think most safety people would agree. If you set somebody home on the couch, they're not going to recover as quick. They're more likely to end up with some sort of prescription they don't need. They're much more likely to end up with an MRI. So having somebody who understands what things are concerning. So it's extraordinarily important that the people who are performing these roles understand what red flags are, what things are necessary to get somebody to a higher level of care, and what things are not. And so our clinicians are well versed in musculoskeletal injuries. They have all the tools necessary to be able to triage those folks, to keep them with a treatment plan that often allows them to stay on site. We have a lot of employees who are remotely located, and so it's not easy to get them to healthcare. And so utilizing on-site or near-site or telehealth triage is extremely important, to have somebody who is vested in understanding what your mission is, what the job entails, where your people are, what things that can be tolerated as far as providing on-site care without having to interfere with operations is extremely helpful. So those first three things, let's get involved early, utilize on-site or telehealth triage to help direct care. And that can't be just somebody on the phone says, oh, send them to the emergency department or send them to the urgent care. It has to be somebody who understands the work that's being done, the physical demands that are being done for that position, and understands what things can be accommodated and what things cannot. And that goes a long way in preventing a lot of unnecessary care and expense that makes no difference in outcomes. And then, if they do need to go somewhere, or even if they don't, you have to have somebody who's going to follow up. If you tell somebody, okay, I think you can take a Tylenol or two, or ibuprofen. I think you can use a non-rigid splint. You can use rest, ice, compression, elevation, some stretching exercises, and I'm going to call you back in 30 minutes, or I'm going to call you back in an hour, or I'm going to call you back tomorrow, whatever the situation requires, but that there's some continual ongoing follow-up, so that if something changes, they're not just rushing off to the emergency department or urgent care, that you have somebody who's helping coordinate that the healthcare and managing it is extremely valuable. And then, once they have improved, how do you get them back to work or get back to full duty is extremely important as well. So I think first 72 hours of an injury, if you can keep them away from places they don't need to be for the majority of time, they don't need to be in an emergency department. They don't need to be in their urgent care where they'll get some snotty-nosed kid sneezing in their face. You don't need that. You can actually manage a lot of this stuff on site or remotely. Fortunately, in a lot of our locations, we have on-site personnel who can provide, whether that be a medic or if it's a nurse, or in some instances we have an exercise physiologist or a physical therapist who can help us. That a lot of times we can manage that without ever leaving the confines of the work environment.
And obviously that's best case scenario, right? The easy button on this thing is, hey, I have an in-house medical team that's dedicated to my organization, and I got arm's length clinical resources with nurses and providers and clinicians. yeah, that's great, but Dr. Turnbull, what about I'm a 10-person HVAC company,
Yeah.
and I just need to be able to talk to somebody about when something happens where, you mentioned the telehealth triage line. I'll mention one either like simpler thing that I don't, we don't have it listed on this slide, but we have arrangements, and I know it's commonplace in a lot of other occ health practices to where we have like an after hours kind of access policy where I think it's literally a couple $100 a month where our clients can access us after hours for non-emergent issues. And if I have that minor laceration, minor musculoskeletal issue that could be maybe treated and managed, getting that into a care center that can handle that, but not check every, cost outcome and every compliance and OSHA recordability bucket on the way out the door. I think that's definitely.
I think our safety colleagues on the phone call can probably attest that, after hours is a real problem and your recordability goes dramatically up, because if you go to the emergency department, your chance of getting a prescription or an injection of some sort is very, very high. Imaging is probably right up there with that as well, although imaging doesn't make it recordable. But yeah, I think we have a number of clients who have just a few employees, and they can't afford the robust in-house medical care that we do for some of our larger clients. That's okay. I mean, just having a partner who understands how difficult it is to keep people off of recordability, to provide care in the right place, right time. We can do that for somebody who has 1 or 2 employees just as well as we can do that for some people who have, thousands of employees. It's just, what resources are necessary to take care of people may be different for somebody who's got thousands of employees versus somebody who's got 10. But after hours access and somebody who can help walk you through that, I think is invaluable.
The only other thing I would add to this is when we get into like that case management and return to work planning, like I've lived this, I know how challenging this is, where if I'm that HR administrator or I'm that claims person within your organization and I'm responsible for managing your return to work planning or that program, how just much of a monster that is to where, Johnny's off for work, he hurt his shoulder, personal, work related, for this example, it doesn't matter. Employees telling you one thing, you can't get medical records from anybody, you don't know when the next appointment is, they're saying they're clear, they still got a cast on their arm, and they're like, well, no, my doctor told me I'm good, and maybe they got a note from their personal doctor that says they're good, have no idea what they're clearing them to return them to. So, like, the best practice of having someone support you through that, and like, I guess this is my question to you, like, the ability for you as a medical professional to reach out and get the real facts peer-to-peer with another medical organization versus having that filtered every other which way, up, down, left, to right, is just so much more efficient. You care to hit that just quickly?
Yeah, let's first start with, in today's healthcare world, you can get somebody to write you any note that you want, right? You can find a doc in the box or a practitioner anywhere in this country to write you pretty much anything you want if you're willing to pay for it. So just because you have a return to work note does not mean that you're ready to return to work, in my opinion. So as an employer, you are a sitting duck if you're just taking return to work notes at face value and letting people come back to work. I think we catch a lot of things that are not or have truths or not appropriate care, where people are partially treated and they really have no business being back to work because of some safety concerns, some medication they've gotten, some half-hearted treatment, and still have a significant impairment. So our return to work process, we take that extremely serious. So from an instance, if it's a personal illness or injury, and we allow them to come back to work with one arm or on some opioid pain medication and we never know it, then when they do get injured at work, now it is our responsibility because now it's a work-related injury. So we definitely take our return to work process very, very serious. And I think it's hard from an HR standpoint. You don't have any medical training, or if you do, you really shouldn't know people's personal health information. So as a third-party administrator, we have the ability to communicate with the treating clinicians, to look at the records, to make sure that everything is appropriate. and then to examine the patient if necessary to verify that they do possess the physical capabilities and fitness to return to work safely.
Good stuff. Good stuff. Thank you so much. Kathy, how are we doing on time?
It's 1:40 right now.
Okay.
So it depends on any questions that come through.
Well, we'll pick it up here a little. We'll pick up the pace because
Don't tell me to quit talking.
No, we're good. I think we just got so much good stuff to unpack here. I want to make sure we have. I think we're right there. We got 2 or 3 more slides, and I want to make sure questions and dialogue. That's really where again our priority is for today. But again, everything we said up to this point, I think, can be kind of captured in this slide between. These are kind of our 5 buckets or 5 pillars, if you will. I think Dr. Turnbow, really did a good job of hitting, buckets 1 and 2 and 3, coming out of the must-haves and must-dos within that first 72-hour window. The only really thing I would add to this is, pillar 4 and 5. We live in a very different world as far as data analytics and insights as it relates to healthcare. This is something that's literally changing daily as far as what we're able to do. All things, the buzzword AI, I hate to say it, but we are seeing some really, really cool revolutions in kind of the data analytics, insight functions of things that we're able to do today. One example is just like care gap and chronic disease management, right? Like, there are some tools out there today that did not exist 2 or 3 years ago that can literally take the utilization trends within your insurance product and identify high-risk claimants within your organization and say, you got 14 people diagnosed with diabetes. 80% of those folks are non-compliant because there's no record of medication refills or appropriate lab testing or what have you. And now we're starting to have like laser focused insights where we can take that data back to your medical partner, which whether it's us or not, we should be able to take that data and say, okay, give us your marching orders. We're going to go out, we're going to engage these folks, or we're going to help, manage and kind of verify what the status of these things are. Would you add anything to that? Or
no, I think that is one part of healthcare today that I think has significantly improved is a focus on preventative care and care gaps. Now, let's be honest, where that all came from is insurance companies wanting to save money. I'm not under the illusion that they really care anything about patients, but as a clinician, I think it's fantastic to have information on compliance to the medications and treatments that we're prescribing, and then having insight into people who haven't followed through on their medical monitoring, and or people who are outside the realm and maybe not even know it. I mean, sometimes people have blood tests, through whatever mechanism, whether it's from a wellness screen, biometrics, or from they go to an urgent care and have a blood test. The data is good enough now with centralized reporting that we can identify people who have elevated glucoses and A1Cs and maybe not even know that they're a diabetic, and offer them an opportunity to impact that or change it before it becomes catastrophic.
Another way, just quickly, to look at this slide is we want to create a 360-degree wrap around your employment life cycle within your organization. So let's kind of bucket this out by job function. So before someone's even in your organization, when we look at, pre-employment, post-offer job testing, Dr. Turnbow alluded to, we're getting into buckets 1 and 2. When we start talking about like healthcare activity that's taking place within your organization, injuries, case management, that's kind of getting into pillar 3 here. Like, how do we optimize medical activity that's taking place within your operations? And then bucket 4 and 5, that's a lot of getting into, okay, what if we do have something happen? We run into, care gaps, injuries, people off of work, whether it's personal or work related. What is our strategy to get those folks back to work to create that, workforce readiness at the end of the day? Kathy, let's jump to the next slide. Quickly here, we've hit a lot of this. I won't go over it again, but the reality of what we're up against, inflation continues to rise. I think I read a statistic somewhere that healthcare inflation, isolated inflation ranks higher than any other inflation category across, the United States at least. I think it maybe doubles the inflation rate of college tuition increase. Like we hear about people talking about how the cost of college is different, 10 or 20 years ago versus today. Well, healthcare is even worse than that, unfortunately. We know that we're up against, labor shortage challenges, regulatory scrutiny is at an all-time high. I think we have some talking points here at the end where we can add our perspective of what we're seeing with ADA and EEOC, kind of claims. I know you're very involved in that, Dr. Turnbow, with a lot of our employer partners. But, employees, despite all that, expect better access, and, the health benefits of your organization are now a bigger retention and recruiting differentiator now more than ever. Jump to the next one. Okay, real world results. I don't think we have too much to add on here that we've already said. Here's, some major kind of outcomes that we would like to see with a strategic, occupational health program. I would say, Dr. Turnbow, we were privileged a couple of weeks ago to kind of present a real world case study, 12-month case study where we implemented these exact pillars for a large employer, where we achieved a 60% injury reduction and a 40% injury severity decrease within a 12-month period. And this was already a relatively safety-sensitive, safety-strong organization.
Highly regulated environment.
Highly regulated environment. We can't name the employer for this discussion, but we came in, we took a lot of these basic pillar kind of foundational principles that we're talking about here today on this webinar and said, okay, how can we operationalize these for your organization? And 60% injury reduction 12 months later. It's pretty wild.
Yeah, I mean, it's just being a partner with the employer to understand and control every touch point with healthcare, where traditionally it's been fragmented. And when we founded HealthWorks in 2007, we talked about these buckets. I mean, each one of these buckets is typically where somebody, and usually it's somebody different within the organization, interacts with healthcare. Because typically it's HR on the pre-employment standpoint. It's usually HR on the annual wellness kind of choice that is usually driven by the insurance product. And then it's usually safety when they get injured, and then maybe claims and legal aspect on the injury as well. And then it goes right back to HR on the return to work or operations, depending on the organization. And so you've got multiple different people individually touching usually a different healthcare provider for each one of those things. And it's so fragmented that the left hand doesn't know what the right hand does. And you have such valuable opportunity to impact the quality of each one of those things if you just, aggregate them together.
Absolutely. Absolutely. And this really just leads to our last slide here. And this is everybody's kind of just quick heads up on we're about to get into questions and answers here next. So if you have something, just please start letting us know, drop it in the chat. Cassie's monitoring those. But I take home message for today is, your occupational health strategy is not, it's beyond just a cost center. It's a competitive advantage. Companies that are going to win in the future are going to treat healthcare strategically, just like you treat other functions of your business strategically already, right? I guarantee you, most of you have some sort of strategic or operational plan for your business development, your sales and marketing, your talent management, your recruiting, your operations, your back office. Like, our challenge to you is like, well, what is your force health protection and your occupational health strategy? Like, we should all have that. It's that important in 2026. And unfortunately, it's going to get even more important as we move forward. So I think if I know where we're at here in the presentation, we're kind of rounding out are we leading? Yeah, I think here we are. I know that was a lot. That was a kind of a fire hose blast of information, but I hope there were some tactical things and some granular things that you guys walked away with. If you have a question, please drop it in the chat. We have a few more minutes here. We would love to answer those questions for you the best we can. We'll do it live, just kind of here off the top. So feel free to drop one in the chat or send us. You can send Cassie an individual message if you need to. Any other closing thoughts, Dr. Turnbull, before we get into questions and answers here?
No, I know we've said a lot, and I would be just interested to talk to anyone. I think, we are more than happy to have conversations and discussions with folks and kind of give them some advice. I think we regularly will look at people's their current working strategy and kind of just give them some advice on what things that could change, whether we're going to end up doing the job or not. We're just we are happy to kind of look at what you got going and offer you some advice with no obligation.
Absolutely. Yeah. Thank you for mentioning that. Cassie, anything come across your chat yet? Any questions that you can see?
Yes. There looks to be one from a maritime employer. Do we have any data analysis regarding how many employees request a second opinion?
Especially if sending an on-site PT and no imaging. Dr. Turnbull, you want to take a crack at that one?
Yeah, so our success rates show on remote monitoring musculoskeletal injuries and keeping them on the vessel, I think is kind of what we're talking about, and how often do they seek a second opinion. And we can give yes, we have that data. Our exercise physiologists and physical therapists track that data and report that out, but our return to work and staying on the boat ratio is extraordinarily high.
I think it's depending on, I'm a little confused on the exact perspective on the question here, but Kelsey, if this is asking, like when we do early onset intervention on the vessel, we have a very strong track record of almost 12,000 different telehealth encounters now year to date. We're able to keep folks on the vessel working 70% of the time.
Yeah, I think 76% is the last thing I remember seeing, is that so of 12,000 calls, over 70% of them stayed on the vessel and got back to full duty without ever having to go off the vessel to a secondary site to get any more interventions, to get physical therapy or any other imaging. So I guess the answer is, 76% of the time out of those 12,000 visits roughly, were able to be treated and maintained and the case closed on vessel.
And Kelsey, there's some other things, Kelsey, we can mention here. There's some components of that are extremely important where, okay, what resources are available on the vessel? Do we have mobile pharmacy kits? Do we have mobile kind of like exercise, musculoskeletal, non-reportable OSHA intervention type care that we can extend? So great question. Maybe worth a follow-up question. We even actually have a case study that we just published with American Waterways operators last fall that we shared at their safety convention that we'd be glad to share with you. Feel free to reach out. We'd be glad to give you some more specifics on that.
I think the most important reason for being successful with that is that you can't tell somebody, oh, you don't need an x-ray, you don't need any further treatment, we'll call you back in a week.
Yeah.
That does not work. What does work is you are intentional, you pay attention to the complaint, you validate that they have an issue, you express concern, you're routinely and regularly following up, you're giving them specific things to do from an interventional standpoint, and you're reassuring them that at any point, if you need further care, we're going to make sure you get it, and that makes all the difference.
Yeah, thank you for the context there. I see your follow-on answer. Yeah, that doesn't surprise us. Unfortunately, I think we've seen that before.
Yeah, so the follow-up is critical. So, with each company, we have dedicated case managers, nursing staff that will, and in the case of a musculoskeletal injury, our exercise physiology and physical therapy or kinesiology division will follow up with them routinely. So if someone goes home and they don't have anybody following up with them, nobody to call if they have an issue, their natural instinct is going to go seek care somewhere. And so we're pretty good at making sure that, hey, if you have any change in condition or any issue, call us, and we'll be readily available after hours or whatever it is. So I think that's important.
Yeah. Thanks, Kelsey. Good question, though. What else, Cassie? Anything else come across?
Yes. I see one, and they asked, where do we see the biggest legal or compliance risks for employers today whenever it comes to workforce?
That's a good one. I'll do a quick stab at it.
Go ahead.
I think probably the bulk of what we've seen lately, and this has probably changed over the past 2 or 3 years, but the biggest kind of compliance risk that I'm seeing with a lot of our current partners is in kind of that ADA, EEOC realm, more on the pre-employment side. When we get folks trying to kind of go through that pre-employment medical screening or post-offer process, we run into something, and now we're getting into, well, hey, hold on, you're telling me I can't be hired because of X, Y, Z. We've really seen a spike in those cases over the past several years. And I think there's a stigma around that where a lot of employers still don't fully understand that you 1000% have an ADA and EEOC compliant mechanism to route, filter, and screen for those types of conditions that can be risk for the job description and job and function that you're asking these folks to complete. But Dr., I know you're on a million different kind of, legal engagements and folks where you're getting brought in to consult on those cases. What's your perspective on that?
Well, I think, first of all, and everybody on this phone call is going to understand, anybody can hire a lawyer. You'll find one to bring a lawsuit. I think EEOC and ADA challenges are always going to be there. Fortunately, I think we have won every one we've been involved in because we understand ADA and EEOC. We're not going to deny somebody employment or not going to recommend that somebody not be employed because they have a chronic condition or medical condition. What that may result in is recommendation for accommodations. And then the question to the employer is, can you accommodate this or not? So we understand EEOC. I think a lot of employer or folks in our world may not understand EEOC and ADA. We have to be fair. You treat everybody the same. That's why we tend to recommend very strict policies and procedures for the company, that we treat everybody the same, and that if you accommodate a condition for one person, you need to accommodate it for all. I think that's really where you get into problems, is if you pick and choose. You accept to accommodate Joe Blow because he's the nephew of somebody in your organization, but you don't do that for somebody else, then you can expect to have a problem. But if you can accommodate it today for this employee and you're willing to accommodate that for everybody in the future, then you don't tend to have problems. But no matter what you do, somebody is going to hire a lawyer and somebody's going to challenge that. But because we understand ADA and EEOC, our defensibility and our success ratio in defending that for our partner clients has been extraordinarily high.
Thank you. Yeah, good answer. Good answer. Anything else, Cassie? Anything else come across?
Yeah, one question just came through, and they asked what our coverage area is for pre-employment screening.
That is a great question. Great question. Yeah. So obviously we're corporately based here in Western Kentucky, strong presence here in the Midwest, but we actually have a very large strategic partner network that we've been privileged to build over the past almost 2 decades now, supporting some of the industries that we support that are very mobile, like the maritime industry, like Dr. Turnbow alluded to. So in short, it looks like that's from Michaela Harper. Yeah, we operate nationwide. So kind of the way we interface with and support our clients is if the phone rings and it says, hey, I'm trying to hire this guy or this gal, and they're in Seattle, Washington, and I need to get them through this process. We have a whole division within our company that is kind of set up to quarterback that process for you, where we can vet a clinic, make sure they're capable to meet the job screening that we're asking, your employee to do, that we've kind of validated that process and protocol. We will help schedule that appointment with that clinic, have the results flow back to us as your medical partner.
I don't mean to interrupt you, but what I was saying about EEOC and ADA, consistency across your pre-employment is extremely important. So centralizing your pre-employment process. So in this instance, whatever industry you're in, when we start working with you, we're going to identify what your essential job tasks are, what your job descriptions are, and we're going to then develop a protocol that is going to be followed no matter where in the country your employee goes for post-offer testing. And we are so detailed about this. It's a stepwise approach. So if we choose a partner clinic to perform these services in Seattle, Washington, or in New York City, they're going to perform the job task or post-offer employment testing to the exact same sequence and the exact same mechanisms that we ask them to do. And we do not let them make the determination on whether or not the employee is fit for hire or not. They collect the data for us, they send it to us, and we interpret that centrally. And I think that is a really important way in which we avoid, treating people different, because it is all collected in the same manner. All that data is sent to the same central location and is interpreted by the same people for your company, no matter where they're getting the actual data collected from. What tends to be so problematic is you never know if you leave the decision to whether or not someone's fit for hire or not to I keep saying doc in the box, but to a provider in Iowa versus a employer here or a provider here in Kentucky. It's the interpretation of that's going to be widely varied as it'll blow with the wind, because those clinicians in those locations tend to change as well. So we're a stable entity. When we sign up to work with you, you'll have a dedicated staff that will not fluctuate from moment to moment. They'll understand your specific needs, your specific demands, and they will follow through on collecting that data, holding that data to the standards by which is your policy and procedure, and then give an interpretation. I think that just makes things so much smoother, and also so much more defensible when it comes to EEOC and ADA evaluations.
Absolutely. Well, I think we are right at time. I do see a few more questions coming in. I think moving forward here, we would love to field as many other questions as you have. We can set up some one-on-one time here to connect and follow up with any other incoming questions.
The last question real quick.
Which one was it?
Case management for employees that are on personal medical leave.
Oh, yeah.
Okay. Yeah. Absolutely, 100%. I think when we were talking about the biggest risk to the employer, that was one of my first thoughts, is that letting people come back from a personal medical leave without any type of medical oversight or review of their fitness to return to work is a huge risk to employers. So yeah, absolutely. That's kind of one of our fortes. We do that regularly. So if you sign up, if you work with us, your individual RN case manager and their medical support staff will collect that data on why they were off, make sure that it makes sense, and make sure that they meet all of the criteria. If they need to come in for actual return to work examination, they're going to set that up. They're going to get those reports in, and they're going to give you a thumbs up or a thumbs down or caution on whether or not the patient is or the employee is safe to return to work.
Great question, Kelsey. And yeah, Kelsey, let's connect and unpack that a little bit more. And everybody else on the webinar that attended today, just thank you so much. And we love having these conversations. We do have kind of a standing open door offer to where if you're out there and you're dealing with some of these questions and challenges, and you just want like as Dr. Turnbow mentioned, just a no obligation 10-minute kind of conversation with us to bend our ear on, hey, how would you approach this, whether it's us helping you with our services or not. Me and Dr. Turnbow take dozens of these calls every single month. It's really one of my favorite things to do, day to day, is just really support the folks on the ground and you guys with these challenges and help you come up with solutions. So we would love to help you unpack that and kind of think about a strategy. Thank you guys so much for attending. Our contact info is here on the slide. Cassie, I think we're going to send this out to the masses as a recording for those that couldn't attend live. But thank you so much. Any parting words?
Oh, no, we love what we do. I think it's really a privilege to help people I think HR, safety, operations, those are really hard jobs to just begin with. But to do it and interact with multiple different healthcare providers can be a real pain. And so it's just kind of fun to develop solutions to that with our corporate partners.
Well, thank you guys. As always, thank you, Dr. Turnbow. Thank you, Cassie, for supporting us and helping us manage this thing. And hope to be back here soon with another webinar topic to support you guys out there in the field doing the real hard work. So thank you guys for the privilege and opportunity to have this conversation today. Until next time.